We go beyond the journal articles and into the laboratory and the field as scientists share their discoveries in a way everyone can understand. It's science explained. You're listening to Science Sound Off on Texas A&M Health Talk. Welcome to Science Sound Off. I'm Christina Sumners.
And I'm her co-host, Tim Schnettler.
And we're here today with Dr. Jodie Gary from the Texas A&M College of Nursing. Welcome to the show.
Hi, thanks for having me.
So we're excited to have you. So you research something called positive deviance. What does that mean?
I do. So positive deviance sometimes is kind of considered an oxymoronic term because it doesn't make sense to a lot of people. But if you consider looking at outliers and toward the positive end, so if you consider a bell curve, I really like to look at anything to the right of that bell curve toward that little tail end. So in positive deviance, you really want to take, like in a healthcare issue, those who didn't have the problem, but you would have expected to have the problem. So if you consider who is least likely to succeed but did, sometimes people want to refer to it as resilience, but it's really not resilience. It's beyond resilience because you have an exceptional outcome.
And even higher than the other people that maybe had better things to start with.
Right.
Okay.
So if you look at kind of a level playing field as everyone having the same access to the same resources, you want to look at those who had an exceptional outcome.
Okay.
Really, the term was coined back in the 90s in Vietnam. The Sternins, Jerry and Monique, who are lovely people, they were nutritionists, and they were given a 6-month visa. Monique Sternin is still at Tufts University. Lovely woman I met with her last summer. But she was given this 6-month visa to solve the malnutrition problem in Vietnam.
In 6 months?
In 6 months. As a Caucasian woman going into villages. So a lot of what positive deviance looks like instead of taking the traditional, you diagnose a problem and you fix it, you go in and you work from the bottom up. So they originally went in and were a little bit overwhelmed with how do we solve this problem. So they started with the basics. They weighed everyone. They weighed all the kids. And then were overwhelmed with the amount of malnutrition that they could just see from the weights. But they started noticing little pockets of a kid was a normative weight. And then they would find in another village, another kid was a normative weight. So what they did, instead of kind of implementing a whole anti-malnutrition program, they went into these homes and did a qualitative analysis of what are these people doing that is different? How do they have a normative weight child in this mass of malnutrition? And so what they found is that there were some non-normative behaviors that were not really culturally accepted, but the families were doing them anyway, such as they were stirring the soup, which normally the men got fed from the bottom because all the protein falls to the bottom. And the women and children got fed from the top up, but they were stirring the soup. The women who worked in the rice fields were bringing a separate bag with them, and they were picking up little crabs and shrimp and adding them to the soup. They were using the tops of the sweet potato shoots, which are normally just thrown away, but they're nutrient dense, and they were throwing those in the soup. They found that older children were actively feeding their siblings. You know, normally you put a 2-year-old in a high chair or wherever and you put food in front of them, maybe 50% of it goes in the mouth.
Right.
But if you actively feed them. So they found kind of all these little idiosyncrasies. And so these families didn't know that they were the positive deviants. But when you collected all this qualitative information after finding the quantitative outliers, they found that they could develop a program where the village themselves could feed the program back to their own villagers. So women would meet with other women in huts and kind of share, this is what I did to get my child to be of normal weight. And then that innovation spreads, and it's developed kind of at the ground level, so that it's more socially acceptable.
But it's taking practices that some people at least were already doing.
Yes, and they didn't know they were deviants. So my dissertation research, I actually looked at critical care nurses who had non-normative behavior, but their goal was providing patient-centered care. So really what I found, I did a concept analysis, and I found that positive deviance requires intentional behavior. You're intentionally doing something, so it might be you're intentionally breaking a rule, but it's for the good of the patient, but it also involves some sort of creativity, innovation, adaptability. And then there's also a little bit of a risk factor, because if you're breaking a rule, then you could put your license at line, or these women in the village, they were going against some of their cultural norms.
So tell me more about your dissertation. You studied critical care nurses and how their patients did. So you studied the ones who had patients who did better than expected, or?
I actually wanted to, one of the first things when I started looking at positive deviance in healthcare, it's been studied with looking at hospital-acquired diseases, hand washing. They've used it in some instances with condom use, and they've used it with some pregnancy outcomes. Anyway, I wanted to actually look at critical care nurses and see if this was happening. My background is critical care, and I just knew that at the bedside at night, there were decisions that I was making that were not necessarily in line with the kind of black and white policy I had in front of me. I look at complexity theory, so I consider the fact that people are complex adaptive systems, and if you go into a room, everyone is a little bit different. And so if you can focus that on patient-centered care, every patient is a little bit different. So if I go into your room and I look at what I consider a very gray patient, being not black and white, but then I only have a black and white policy to follow with which to care for you with, I might need to adapt that to be able to meet your needs. Probably a good example is I would go into a room to change a dressing on a patient for a central line, which is like a catheter that you can give medications through. And we have a specific kit, and it has a little 2x2 piece of gauze and a very small little tegaderm to put on, and there's a very specific policy that you follow. So I go into the room, and my patient is 500 pounds, and the line is in his groin, is in an artery in his groin, or a vein in his groin, sorry. And if I cover it according to policy, well, it's really not going to stick. It's going to roll up. It's going to get caught up in skin and tissue. There's risk for infection. And so I would find that I would slightly adapt that. And we had these really big chest dressings, so I would use a big chest dressing. But then when I would go back and chart, I only had a little box to check that said, did I follow policy to change the central line? And there was really no place to outline that, okay, I didn't follow policy, but
here's why, yeah.
Here's why. And so during my PhD, I was taking a class looking at health outcomes from big data. And I was considering the fact that if nurses don't have a place to articulate their, adaptable, creative, non-normative type of work that they did, that when they didn't follow a policy, what are they doing? So my first place to start in my dissertation is I did a concept analysis of positive deviance within nursing. And then I wanted to ask nurses, what are you doing in these situations? But I can't just ask you, are you a positive deviant and what are you doing? Because nobody knows what that term is.
And I'm sure if they hear the word deviant, they'd be like, no.
Yes,
exactly.
Yes. In fact, I did have someone on my dissertation committee that vehemently asked me to change that term. And I would not. It's a real thing. There's an international society looking at positive deviance. So what I ended up asking these nurses, I used a Delphi study, an electronic Delphi study, because I wanted them to have some anonymity because they were going to tell me about times they were breaking rules. And so I just asked them one open-ended question in a national survey of critical care nurses. Tell me about a time where a policy didn't fit the needs of your patient, a policy guideline or procedure, didn't fit the needs of your patient, and what did you do? How did you handle that? it was fascinating to read these. And I gave them open-ended, open, no word count. And so going through and reading kind of this qualitative, vat of here is exactly what I did and what happened, and then really having to go in and break that down to what did they actually do. They gave fluids without an order. They might have changed a medication dose. They allowed more visitors at the bedside. They adapted care at end of life. Lots of things, but in it there was almost this guilt too of that they knew they were breaking a rule. They would follow it up usually with, I got an order later in the morning, or I consulted someone at a different time, but it really came down to it is they were adapting care for the need of the patient. A lot of times they had the outcome was great, but they had really no place to discuss kind of the rule breaking they were doing. So it was pretty fascinating to read. I put them all into kind of a list of all the basic rule breaking things they were doing, and it fell into some categories of care at the end of life, care in emergent situations, which in critical care is pretty common. Medications, there were times where they were adapting medications. Some of it was patient preferences, where a diabetic knew their own body and said, if you're giving me that much insulin, bad things are going to happen, so can we try half? Or sometimes they adapted it looking at, the routine medication dose was a regular dose, but the patient may be a small stature, and they thought, let me try half of a dose. But then at the end of the day, they're putting their license at risk because they're changing medication order, outside their scope of practice.
So being from a critical care background, were you surprised when you saw this, or was it something that you kind of expected going into this research?
It's funny because I completely expected it because it's things that I had done. It's things that I had worked with other people that had done, but we just didn't talk about it. So really some of my goal in writing it up was making that undiscussable more discussable. Sometimes I frame positive deviance in looking at a wicked question. So you kind of ask a wicked question. Right. One of my favorite wicked questions in relation to nursing is, how in a caring profession do we eat our young? When new nurses come in to the hospital. And so you can kind of open up those things to make them a little bit more discussable.
So your background in critical care nurse, is that what drove you to this? I mean, how did you get,
yes.
Is that what brought on the desire to go into positive deviance?
It did. I started actually looking at, didn't arrive on the term positive deviance immediately when I started my PhD program. Right. I was playing around with the idea of how do we make decisions and how do we learn to make decisions? And there's a lot of literature and a lot of research on decision making. But I really wanted to understand the why I was making some of the decisions that I did. Where do other nurses learn to make those decisions? When I did my study with critical care nurses, I only wanted experienced critical care nurses. I wanted those that could articulate why they were breaking a rule and how they were breaking it and what the outcome. I didn't really want that novice nurse that would come in and, sometimes you can just follow all the rules and still have a bad outcome.
Right.
So you wanted someone who knew enough to know when they should tweak things a little bit.
Right. One of my favorite terms that I found in doing a concept analysis was a term called responsible subversion. So Hutchinson out of Florida in the 90s had done a study looking at critical care nurses and their rule breaking. And I really focused my literature search on positive rule breaking, if you will. And so that term really resonated with me, that responsible subversion, that you know you're breaking a rule, but you can articulate why.
And why that's going to be better for your patient than following it.
Right.
So what did you study next after you finished your dissertation? Did you keep going with positive deviance in critical care nurses, or?
I did not. And there's actually, I would like to go back and follow up on some of the things that I learned from the critical care nurses. When I started at the Health Science Center, we had a lot of time for building courses and getting the College of Nursing up and running. And so I really just of late have really tried to get back into positive deviance and focus on it. I did meet with a international positive deviance group in Denmark a couple years ago. There's about 50 people in the world that really focus and look at positive deviance. There's a few in healthcare, but not a lot. There is a lot in communications that look at positive deviance. And again, they look at hospital-acquired diseases within positive deviance. Probably one of the most interesting things is to look at when they looked at spreading MRSA between hospital rooms. There was one unit where they were not having this problem, so there's your outlier. So they went into that unit and said, so how is this not happening? And they found that they were changing, the guy who cleaned the rooms changed the mop heads between the rooms.
Oh, wow.
So now it's interesting, you go into hospitals now and you see those disposable mop heads that come off and they get laundered.
Yeah.
So some of the innovation that comes out of really drilling down and looking at the frontline problem. The thing that I like most about positive deviance is probably the bottom-up approach, is looking at the people who have the problem, have the solutions. Most of the time they don't realize they have the solutions. They figured out the workaround, and that you really have to find those that have had the uncommon success and then kind of drill down into how did they figure this out. So that's why it fits well with mixed methodology, because you're finding the quantitative outlier and then you're doing that qualitative piece to really go in there and look at it. I've submitted a grant currently to look at chronic diseases within this community. I really want to know those who are the sickest of the sick. Who is not accessing hospitals, who is able to care for themselves and stay at home, and then how are they doing that within this community? Because I think that's a really interesting piece, that if we can feed that back, we can really help with the 30-day readmission rates. I'm currently looking at a scoping review of HIV patients and how patient-centered care is represented within the HIV literature, because it's a disease with a stigma.
Sure.
And so if you are non-normative and you don't want to be on the everyday regimen because of very specific reasons, and then how are you living this long, healthy life? What kind of things can we learn from people like that? So there's a lot of applications for positive deviance. Usually when I sit with a group of other researchers and they talk about their research interest, I view everything through that lens.
Sure, yeah.
Where I want to know. So you're looking at this problem. I want to look at those that don't have the problem, but you think should have the problem.
So they're basically looking for the solution, whereas you're going the opposite direction.
Yeah, sometimes I look at it as... I think that the negative screams and the positive whispers, so sometimes that's why it's really hard to find the positive sometimes, especially in healthcare. That's what we're trained to do. We're trained to find the deficit and then fix it. And really positive deviance is very asset-based, so it's finding what you do have and what is working well, and then how can we amplify that. Sometimes I consider it is expanding a solution space. It's really hard when you try to articulate a proposal sometimes, because with positive deviance, you don't really have a hypothesis. You can maybe say, I might bring you a basket of solutions that we can then work from and then develop an intervention, but I can't tell you that X is going to be the answer.
Yeah. Right. You can state the problem, but that's the research, is finding the solutions. So you don't have an idea in your head going in of what those might be.
Right. Another interest I would love to look at with positive deviance, only because I have a girlfriend that looks at epiphanies in healthcare. So she wants to know how people get this what she calls a health epiphany. Like, how do they weigh 400 pounds and then suddenly one day they wake up and they're like, I'm going to fix this. And then they do. Yeah. And then they have this healthy lifestyle. And so I keep thinking of that show, The 600-Pound Life.
My 600-Pound Life.
Yes. But the beginning starts off, and she actually called me. She's at UT Tyler. Her name is Jenny Chilton, and she called and said, every time I watch that show, I think of you, because they say less than 5% succeed.
Oh, wow.
And so that's my first question is, who are those 5%?
5%.
And how are they succeeding?
Yeah,
what are they doing? How are they beating the odds? Dr. Nazardin is in Houston, and so it's I think it would be fascinating to reach out to him and say, okay, you have oodles of videotape footage, and you obviously already have a population that has had their life followed. You could do just a qualitative analysis of just those videos to see. So that's kind of next on my, I think that would be cool to do.
Wonderful. So you mentioned resilience and how that is not the same as positive deviance. What's the difference between them, and how would you explain that?
So I'm actually working on a concept paper currently looking at the current concept analyses of positive deviance and then the concept analyses of resilience. There is a lot of work and literature on resilience, and I'm not a resilience expert, so it's taking me a little bit of time to get through that. But there are several concept analyses of resilience in healthcare. And then there's actually only 3 concept analyses of positive deviance in healthcare, one of which is mine, so that's probably a little self-serving. One is by a group of French Canadians, so I need to get the article translated. But it's really fascinating. So they do overlap in some instances with some of their concepts. But resilience is you've just overcome something, like you overcame your cold.
Okay.
But and positive deviance is you had an exceptional outcome.
Okay, that makes sense.
And you were in the direst of circumstances. And so they do overlap quite a bit, but I'm really excited to kind of get into that paper, so there might be more to come for that.
Okay, well, we'll have to get you back on to talk about that. But in the meantime, thank you so much for being here.
Thank you for having me.
Great to talk to you. And thank you all so much for listening to another episode of Science Sound Off. We'll see you next time.
Thank you for joining us on Texas A&M Health Talk, a production of the Texas A&M University Health Science Center. Visit us on the web at vitalrecord.tamhsc.edu, where you'll find answers to all of your health questions. Until next time, stay healthy.